Hi guys, welcome back to the channel. Today we are discussing the bi-level APRV. Early application of airway pressure release ventilation may reduce the duration of mechanical ventilation in acute respiratory distress syndrome.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question for this study. The mechanical ventilated patient with ARDS does airway pressure release ventilation APRV compared to the conventional low tidal volume ventilation reduce the duration of mechanical ventilation. Background for this study. Acute respiratory distress syndrome is an inflammatory process featuring increased lung vascular permeability resulting in hypoxemia and reduce the lung compliance. Conventional ventilation is based upon the ARMA trial, which has become known as ARDS net or low tidal volume ventilation. Small trials and animal studies have suggested that longer period within a ventilation cycle at high pressure with intermittent release to low pressure, known as airway pressure release ventilation, may be beneficial by the improving the alveolar recruitment, gas exchange and reduce the lung. Design for the study. Randomized control trial, ethics approval in accordance to the Helsinki Declaration with informed written consent. Trial registered as a bi-level APRV to prior with no change in primary outcome. Randomization sequence generated by the computer block design. Concealment of allocation by opaque envelopes. Small sample population drawn from the consecutive patient. Allocation not blended. Open label design. Power calculation based on the previously published data. Low tidal volume 14.5 ventilator free days. Expected absolute difference with APRV 5 days. Power at 80%. Significance set at 0.505. 138 patient required, which includes allowance to drop out. Statistical analysis using the appropriate test. Settings for the study. Single center study in Sichuan province, China. And duration for the study May 2015 October 2016. Population inclusion criteria. Diagnosis of ARDS upon due to the Berlin criteria. PO2 FI2 ratio less than 250 mmHg. Endotracheal intubation, mechanical ventilation for 48 hours more than. Exclusion criteria: antiseptic mechanical ventilation less than 48 hours, neuromuscular disorder that prolong the mechanical ventilation need, intracranial hypertension suspected of one, severe COPD, treatment with ECMO at enrollment, refractory shock, known barotrauma, age less than 18 or more than 85, pregnancy, less than 6 months predicted life or lack of commitment to life support, 251 screen, 138 patient randomized, 138 in intention to treat analysis, 118 in the per protocol analysis. Baseline characteristics between the groups including a region for ARDS were not significantly different except for the presence of coexisting disease or disease. APRV versus low tidal volume ventilation. Age, Apache score, diagnosis of cancer, any coexisting disease, pneumonia as a cause of ARDS. Intervention for this study. Airway pressure release ventilation. Initiation between patient were transient from various volume assist control ventilation to the APRV. Pressure high was set to previous plateau pressure measure not exceeding the 30 cm of water. Plateau pressure was set 5 cm of water. Tidal volume, the duration of lower pressure was set 1 to 1.5 expiratory time constant. T is the time required for the 63% volume to be expelled. T is resistance of respiratory system into static compliance. RRS and C static compliance are measured during the inspiratory pause. 3 times of lower tidal volume, lower pressure is time required to expel full volume down to residual volume. Low tidal volume was subsequently adjusted to the expiratory flow rate was 50% peak expiratory flow rate. Release frequency was set 10 to 15 per minute. Tidal volume high was dependent upon the low tidal and release of frequency. Initial spontaneous respiratory level was targeted as a 30% of total minute ventilation. Winning if cardiopulmonary function was stable and sedation was adequate. Ventilatory support was reduced twice a daily. Peak pressure was reduced by 2 cm of water. Release frequency was reduced by 2 per minute. Termination patient underwent spontaneous breathing trial when pressure 20 cm of water or less, FI2 40% or less. In this diagram showing the longer period within the ventilation cycle at high pressure with intermittent release to low pressure, known as airway pressure release ventilation, may be beneficial, improving the alveolar recruitment, gas exchange, and reduce the lung injury. Low tidal volume ventilation. Initiation patient were continued to the volume assist control ventilation mode. Tidal volume target was 6 ml per kg predicted body weight. Acceptable range of tidal volume is 4 to 8 ml per kg. PEEP level was adjusted according to FI2 using low PEEP table from ARMA trial. If ARDS was severe, PO2 FI2 less than 100 mmHg, then PEEP could be titrated according to optimal oxygen, optimal compliance, and clinical discretion. Ventilation frequency was set to maintain target pH according to ARMA trial. Winning PEEP and frequency were titrated down as the oxygen and ventilation improved as outlined above. Daily sedation break occurred in Richmond agitation sedation scale. We will discuss the Richmond agitation sedation scale in another video. Was less than 2. Termination patient underwent spontaneous breathing trial when FI2 40% or less, PEEP 8 cm or less, PO2 60 or more, acceptable spontaneous breathing effort, systolic BP 90 mmHg or more with not more than dobutamine 5 microgram per kg per minute, non-adrenaline 2 microgram per kg per minute, no neuromuscular blocking drugs. Management common to both groups. All patients were initially ventilated with volume assist control ventilation according to the low tidal volume strategy using the routine Bennett 840 ventilator from the COVID in. Additional measures that could be used in severe hypoxia were recruitment maneuver, low tidal volume, incremental PEEP increase up to the 40 cm water, APRV, PEEP high or PEEP low increase incrementally until the pressure 40 cm water. Prone position, neuromuscular block, inhaled nitric oxide, spontaneous breathing trials, 30 minutes, PEEP 5 cm water, pressure support ventilation 5 to cm, and FI2 40 or less. Outcome, primary outcome, the number of ventilator free days up to 28 was significantly greater in APRV group compared to the low tidal volume group. Median ventilator free days, APRV 19, low tidal volume 2, P value was less than 0.001. Secondary outcome, APRV resulted in significantly better marker in oxygen and ventilation, such as a better PO2 FI2 ratio, better lung compliance, low plateau pressure or peak pressure. APRV resulted in significantly lower heart rate and high blood pressure. APRV resulted in less sedation depth with a lower doses of opioid or benzodiazepine. Successful extubation rates were higher in APRV group and fewer tracheostomies occurred. ICU length of stay was shorter in APRV group. Mortality hospital length of stay were similar between the two groups. Rescue measures for severe hypoxia occurred more frequently in low tidal volume group. Strength for this study. Interesting theory lacking substantial evidence so far. Reasonable hypothesis, appropriate methodology to test it. Randomized control trial minimize bias from the confounding factors and provide best evidence from the testing to intervention. appropriate randomization process, consecutive sampling reduced selection bias. Clinician could not be choose when to include in the trial as all the patients were considered. Adequate consignment using the opaque envelope, which minimized the selection bias, but web-based system could have been better. Clear protocol care reduced the possible bias from the open label design. Clinician knew which group the patient was in, but treatment was directed by the objective protocol. Weaknesses for this study: single center conduct limits the certainty about the validity of result and prevents the meaningful generalization of this result. Generally, repeat the study with the multi-center design. Find a small effect from the intervention. Important baseline difference exists by chance. APRV group had a less coexisting chronic disease, which have may added to the size of observed effect. Multiple linear regression analysis was conducted to statistically correct for this, and authors report the conclusion remained the same. Awareness allocation. This tends to the leads exaggerated effect size. The intervention and control group protocol differed numerous ways to not just a specific ventilator setting. This including high PEEP recruitment manner, such those have found harmful in the ARD trial. We discussed ARD trial earlier. Winning strategies showed spontaneous breathing trial. It could be said that this trial compared with the ventilation protocol that includes APRV versus ventilation protocol that includes low tidal volume. Many centers no longer use of low tidal volume in the way of protocol specified, which may reduce the general reliability of the result. Wish list: this does not reduce the validity of a conclusion. It does imply that other centers should be asked to see improvement in patient outcomes from simply changing ventilator mode. Respiratory therapists implemented all ventilator-assisted therapies, which not be standard practice in all intensive care units. This reduced the general reliability of this result. Such large difference may not be observed in the same intervention is performed by critical care doctor, nurses rather than the dedicated respiratory therapist. Author conclusion for this: early application of APRV was associated with a better oxygenation, less sedation, fewer days mechanical ventilation, and shorter ICU stays. The bottom line for this study: the reported benefits of APRV are clinically significant, and the conduct of this trial is reasonable enough to conclude the results are probably valid. However, given this single center design, the extensive use of respiratory therapists, I would like to see multi-center, multinational trial before the concluding APRV is far better than LTV, low tidal volume strategy. For now, I shall consider APRV in selected patients with severe ARDS.